Hello, everyone. My name is Denise Adams, and I'm proud to present at this review course information on vascular anomalies, tumors, and malformations. As you all know, vascular anomalies are a new topic area for the boards and very, very essential as many pediatric hematology oncology programs are taking care of patients with vascular anomalies, both tumors and malformations. So our topic follows somewhat the suggested structure from the ABP. We do talk a bit about science and pathophysiology. We talk a little about epidemiology, the diagnosis and the management. But to be really honest, this is a fairly new field, and we've made incredible advancements in the science and pathophysiology. We've also sort of need more natural history studies for epidemiology and risk assessment. We know a lot more about the diagnosis, and we know a lot now about management and treatment. So I'm truly going to focus on the aspects that will be on your board evaluation. So I have to give you some background first. And as you know, the classification of vascular anomalies is somewhat complicated. This classification was initially performed by surgeons in 1982. And very simply, it was based on the fact that vascular anomalies were either tumors because they were proliferative lesions, that there was one cell that was growing, or they were malformations. And malformations were congenital problems that were based on what the vessel of origin was. So for example, low flow lesions were venous malformations or lymphatic malformations, and high flow lesions were arteries or capillaries. We have come incredibly far with our classification, and it is important for you all to know the classification so you know how to treat these diagnoses. And on the board evaluation and exam, there will be diagnoses that you will need to understand. So it's important that you have an understanding of this classification. This classification was changed in 2014. Many new diagnoses were added. Phenotypes and genotypes were correlated. And you can find this on the ASPHO. So ASPHO stands for the International Society for the Study of Vascular Anomalies. You can find it on their website. And it also was published in Pediatrics. And it is broken down into vascular tumors and vascular malformations, but that single page classification that was developed in 1982 is now a classification that spans 20 pages. So I'm going to talk now about vascular tumors and vascular malformations. And I have highlighted with a star the very important things that I would like for you to focus on. So this is a schema, an ASPHO classification, but also the WHO classification of vascular tumors. And as you see, vascular tumors can be divided into benign lesions, locally aggressive or borderline lesions, and malignant lesions. And I have highlighted the lesions that I want you to concentrate on in this lecture. And those include infantile hemangiomas, congenital hemangiomas, which are not infantile hemangiomas, and we'll talk specifically about rapidly involuting congenital hemangiomas. Kaposiform hemangioendothelioma, which is an intermediate risk malignancy, and also malignant vascular tumors such as epithelioid hemangioendotheliomas and angiosarcomas. So we'll talk about infantile hemangiomas first. This is important because these are tumors, even though they are benign tumors, and you can see these are different pictures of hemangiomas, and there's a lot of heterogeneity amongst them. This is what we call a pedunculated hemangioma. This is a deep hemangioma, and this patient actually came to the solid tumor service because they thought that this child had a solid tumor and was differentiated with radiologic imaging that this child had a hemangioma. Again, why it's important to understand that. This is a differential that includes hemangiomas that are segmental or diffuse, and you see diffuse meaning that it spans different segments of the face. face. This type of hemangioma is more likely to have airway lesions, and also this type of hemangioma is more likely to have a syndrome called face syndrome. This, again, is a deep hemangioma, and you see that there was another hemangioma on the side tipping you off that even though you can't see the cutaneous stain, that this is not an aggressive solid tumor, but this is an infantile hemangioma. This is actually a congenital hemangioma, so a patient was born with this. And the point of this slide is that there's a lot of heterogeneity, and you really need to know the difference between an infantile hemangioma and a congenital hemangioma, and also the difference in when you worry about different syndromes associated with hemangiomas. So the epidemiology of hemangiomas is pretty well understood. The cause is not necessarily well understood, but there has been a lot of research in the dermatological literature about hemangiomas. We know that it's the most common tumor of childhood, even though it is a benign tumor. The prevalence is about 4% in Caucasian infants. They're more common in the head and neck area. They're more common in females than males. Again, they have a highly variable appearance. Estimated that 12% or 10,000 infants per year require systemic therapy, so not all patients require systemic therapy. They have a particular growth period where they're not usually present at birth. You might see a slight stain, but then they proliferate, and their proliferative period is between 4 and 6 months. And then they stabilize and involute, and usually the involution is completed by 3.5 years, but sometimes it takes a little bit longer than that. Hemangioma endothelial cells are clonal in nature, and we believe that the etiology of them is because of prenatal hypoxia. And this is secondary to a lot of information that has come out that if there are issues with the placenta, there's an increased risk for hemangiomas. They're also increased in multiple births. So this is what I was talking about of the growth period. So important again to note, so what you will need for the boards is that a hemangioma is again not present at birth. Its growth happens after birth. Then it stabilizes, and then it involutes. So a hemangioma is not going to be present in a patient who is 10 years old. If someone is born with something called a hemangioma, it is not an infantile hemangioma. So important things for you to know. Pro-angiogenic factors occur in that proliferative period, and then anti-angiogenic factors appear when a hemangioma is involuting. They have a very particular appearance on ultrasound, so they're capillary, so they're high flow. They should not look like a mass. And so this is important to know how to differentiate. So for example, if you have a hemangioma, like some of the pictures that I showed you that is deep, all you need to do is have an ultrasound done. And the ultrasound has a very particular wave characteristic and high flow. And a lot of times you can differentiate whether this is an infantile hemangioma or this is another solid tumor. So that is important to understand. Hemangiomas also test positive at all of their life cycles for a stain called GLUT1. And GLUT1 is a stain that is really only positive in the endothelial cells of infantile hemangiomas. It is not present in congenital hemangiomas. And sometimes other more aggressive tumors like angiosarcomas can be GLUT1 positive, but only 20% of the time. You see on H&E stain, hemangiomas are very normal plump endothelial cells that have a high mitotic rate because they are proliferative. And this is the staining that one sees for GLUT1. So if there is any question pathologically, an infantile hemangioma is what is positive with GLUT1 staining. So what are some other things as a hematologist, oncologist that you need to be aware of? Multiple cutaneous hemangiomas, so more than 5 lesions, have an increased risk for hemangiomas in other areas. And the most common place for these to be is in the liver. They can be in other places, but honestly, we don't look for them in other places because it is the liver that will be most significant. So if there is a question on a patient that has multiple lesions and it asks you, what is the testing that you should do for this? You need to do an ultrasound of the liver in a patient that has greater than 5 cutaneous lesions. Then I wanted to talk a little bit about liver lesions that are related to hemangiomas, because in the past, anytime someone had a vascular liver lesion, it was called a hemangioendothelioma, and we are trying to get away from that term. So this is very important for you to know. So when we have a liver lesion and your radiologist says, this is a vascular tumor, it's important for you to understand what kind of vascular tumor it is, and imaging can help, but also whether it's focal, multifocal, diffuse, or if there's cutaneous stains is very important as well. So in the liver, a focal or single lesion that looks like a vascular tumor is never an infantile hemangioma. It is a congenital hemangioma. And congenital means that it is there at birth. And I just told you that infantile hemangiomas are not there at birth. So I'm going to repeat that. Usually focal lesions of the liver that are considered vascular lesions that are present at birth are congenital hemangiomas. Multiple lesions and diffuse lesions that are vascular to your radiologist are infantile hemangiomas. So these are the lesions that are not present at birth. They can form afterwards in days to weeks, and they are the GLUT1 positive infantile hemangiomas. And I tell you this because of the difference in the treatment. So this is an important slide for you to know. This is a patient who presented to me when I was a young fellow with an enlarging abdominal mass. And this is what the CT evaluation looked like on this patient. And I was told that this patient had hemangioendotheliomas. And so when we said hemangioendothelioma in the past, it made us think that this was an aggressive tumor. But what this wound up being, and is, whenever you see something like this, is a diffuse liver hemangioma. So an infantile hemangioma. So as you can see, there's enhancement around these lesions, and then there's central darkening. And this is very typical for an infantile hemangioma that is diffuse in the liver. Now, obviously, you need to look for other things. So obviously, when you have a patient that has lesions like this, you want to make sure that there's no mass in the adrenal, because you could have metastatic lesions, though they don't typically in neuroblastoma have this type of appearance. This really shouldn't be a hepatoblastoma. So this is very characteristic of a GLUT1 positive infantile hemangioma that will respond to medical management. The other thing that you need to know, and there's a star on this slide, is that diffuse liver lesions, so diffuse infantile liver hemangiomas, are associated with hypothyroidism. It is something that you do not want to miss because, as we know, these grow after birth. So the thyroid function may and usually is normal on the newborn screen. But as these hemangiomas grow, they take the endothelial cells uptake thyroid hormone. So the functionally active T4 to T3 is degraded by type 3 deiodinase, and that's in the endothelial cells, and you have significant hypothyroidism. And this was reported in the New England Journal in 2000. This hypothyroidism is so significant that you can need 20 to 30 times the adult replacement of thyroid hormone. And the thyroid can also be used as a way to assess that your medication is working to decrease this infantile hemangioma. So again, just to summarize, diffuse lesions in the liver that have a typical look on MRI and CT scan are usually infantile GLUT1 positive hemangiomas. They can be associated with cutaneous hemangiomas, but sometimes they're not associated with cutaneous hemangiomas. These hemangiomas need to be treated aggressively with propranolol, which we'll talk about, but also remember that they can be associated with hypothyroidism. So when do you actually treat a hemangioma? And so in the olden days, we used to say only when a hemangioma was involving vital structures, so the airway, the intestines, the liver with hypothyroidism, the eye. But now, because we have better agents than steroids, we actually treat hemangiomas a little more vigorously. We do look and consider things like ulcerations of the lip, disfigurement around the nose. So anytime you have a hemangioma of the nose, they really need to be treated. Segmental hemangiomas because they have a risk of ulceration, breast hemangiomas because they have a risk of disfigurement, and anything in the genital area because you also have a high risk of ulceration in those areas. Those are the places that we really think of treating hemangiomas. This is important for you all to know, and this definitely could be on the boards because hematologists, dermatologists treat a lot of hemangiomas, but in the smaller centers, hematologists, oncologists are also treating hemangiomas. And now we have an FDA-approved medicine, which is propranolol. This hemangiol is a propranolol product that doesn't have the sugar and alcohol that initially propranolol had in it. And so this is an approved drug to treat hemangiomas. So why does propranolol work? Well, we know it's a non-selective beta blocker. We know the mechanism of action is because hemangiomas have a lot of flow from capillaries, and so propranolol causes some vasoconstriction. It also can decrease angiogenesis and decrease the expression of VEGF and FGF, and we know that it causes endothelial apoptosis. And actually, there's some other interesting things about propranolol that I can give you references to that say that it works in using other mechanisms, and we're not going to get into that because I do not think that that's going to be on the boards. So what are the common side effects? This is something that I would know for the boards as well. So typically it is very well tolerated. And when we first started with propranolol, we actually admitted patients to the hospital. Propranolol now can be given as an outpatient. Only the very young patients or the very critical patients, such as a diffuse liver hemangioma, or say a lesion that is causing complete obstruction of the vision, needs to be treated in the hospital so that you can get up to the upper dosing. Now we actually can treat in the outpatients, and with the advent of COVID, we actually have been doing for the low risk patients some initiation of propranolol at home if someone is able to see their pediatrician very early on. So what are the common side effects of this? Some of the common side effects that we see are sleep disturbances, such as nightmares and irritability, GI, constipation and diarrhea, though I have seen mostly constipation, acrocyanosis, which really does not cause any issues, though it's very scary for young parents to see blue hands and feet. At times you can get pulmonary issues such as wheezing, and uncommonly you can get symptomatic hypoglycemia and AV block, and uncommonly also symptomatic decreased blood pressure. So very important to know at least those common side effects of propranolol. What are the contraindications for using propranolol? Well, again, in neonates, you have to be very careful. It's been used in neonates that are 0 to 4 weeks of age, but you really need to make sure their cardiovascular system is intact, and it's initiated in the NICU situation, and a lot of these patients are in the NICU because these are the preterm infants. You have to consider drug interactions, especially if the baby is breastfeeding. Reactive airway disease is a contraindication, also AV block, any history of hypoglycemia, and any autoimmune history in the mother, Raynaud's, such as Raynaud's syndrome, any hypersensitivity to this. And you have to be very careful if you have a patient with FACE syndrome, because patients with FACE syndrome can have arterial abnormalities, and you don't want to cause any decrease in the flow in these vessels in the brain. There's also topical medicines that you can use. So timolol, which is used for glaucoma, is a topical beta blocker, and that has proven to be very effective for very isolated lesions. We're learning more and more about the efficacy and the safety of topical timolol, and there's a trial that should be closing soon on 2 different scenarios as far as the percentage. So just in summary for the infantile hemangiomas, again, I think you need to know the natural course of their growth. You need to have an understanding of who are the high-risk patients, such as the liver. You need to understand that propranolol is the drug of choice that we use. I would know what the common side effects are. And the other information that I gave you is for you to have, because you will be taking care of some of these patients, particularly if you're at a smaller or mid-sized institution. So now let's go back. We mentioned congenital hemangiomas a bit, but let's go back and let's talk a bit about congenital hemangiomas. And if you remember, we mentioned them because the single liver lesions are congenital hemangiomas. I hate the fact that it has the name hemangiomas because these are usually single lesions that are fully formed at birth. So unlike infantile hemangiomas, they are GLUT1 negative. And a lot of times these lesions can be picked up in utero. So you actually might have a congenital hemangioma of the liver that you are consulted on by your fetal service because it is picked up in utero. It has the name hemangioma only because it is a vascular tumor. There are 3 types. One is the rapidly involuting congenital hemangioma, and most liver lesions are Riches, so I want you to concentrate on Riches. There are non-involuting congenital hemangiomas that usually do not occur in the liver, and then there are partially involuting congenital hemangiomas. As we talked about, these are congenital in nature. They are present and fully formed at birth. The proliferation of these happened in utero. And versus hemangioma, there's no predilection for sex, so they're equally as apparent in females and males versus infantile hemangiomas that are more prevalent in females. They can be anywhere, and so you can have infantile congenital hemangiomas of the liver, but you can also have congenital hemangiomas of the skin. And I can guarantee you that if a baby is born with this and you are on the solid tumor service, you will be consulted on a baby like this. And it's going to take you a bit to understand that this, if you picked up this tumor, is more pedunculated and it has a halo around it. Sometimes it can ulcerate in the middle, and sometimes it can have draining veins, so it's prone to bleeding. But these are not solid tumors. These are congenital hemangiomas. So these have somatic mutations, and the somatic mutations are GNAC somatic mutations. Sometimes these patients, the ones that are on the skin and also on the liver, can have transient coagulopathy. So they can have a low platelet count that doesn't get as low as 20,000, but it can be as low as 40,000. They can have hypofibrinogenemia, so less than 100, and this is transient, and it's usually due to a big clot that's in the middle of that lesion. So this is a picture of a rapidly involuting congenital hemangioma. So one can almost see that area of the halo around it. And this is a picture at birth. So you see a picture at 1 month. And so this is less violaceous as far as the purpuric color. You see you still have that halo around it. And then going back, this is the residual extra skin with some dilated veins that you see when it involutes. So it completely involutes, but a lot of times you have residual lesions that are there. This is a picture of a KUB of a liver congenital hemangioma. So again, a focal lesion, and you see what it looked like at birth, that you have significant hepatomegaly from this, and 8 weeks, how that has decreased in size. So the average time for these to go away is 15 months compared to 3.5 years for an infantile hemangioma. And sometimes it can be really painful to wait for these to decrease in size. Because for congenital hemangiomas, I said their proliferation was done in utero. So there's no medical management. We just have to give them supportive care. There's nothing that you can do. In the literature, people have given these babies propranolol, but they get better on their own. So it truly wasn't the propranolol that was making these lesions better. They get better over time. This is another picture of how they look. So you can see they have that peripheral enhancement and that central darkening. This looks very much like an infantile hemangioma, so you have to be careful because they look the same. So vascular lesions look the same on CT and MRI. But important for you to know that if it's a liver lesion, again, I keep saying this, single lesions are congenital hemangiomas. There's no treatment available for congenital hemangiomas. You have to wait and they will definitely involute, versus infantile hemangiomas, which are usually multiple or diffuse, and propranolol is the treatment for those. So let's talk now about an intermediate tumor called Kaposiform hemangioendothelioma and tufted angiomas. And I'm sorry for these pictures, but this is what they look like if they've been aggravated. So this first picture was a patient that I had that at 2 months of age had immunizations into her leg that had a very small purplish bruise that really was hardly noticeable. And after 48 hours, this is what the leg looked like. The patient on the bottom actually presented with this indurated purpuric area at birth and was said to have a hemangioma. These are not hemangiomas. You can see by looking at them, these are firm, indurated masses, which are intermediate malignancies, and you need to know about these tumors. So these can be present at birth, but they also appear postnatally. They affect both sexes equally. They're usually noted in one area, but they cross tissue planes. So again, this patient had it in one area of her leg, but after trauma to the area, and notoriously these can get worse with trauma, it grew and infiltrated around tissue planes to be not only this whole leg, but also going over into the other leg and on the back. They're not more common in the head and neck area. They're actually less common in the head and neck area versus infantile hemangiomas. You see what the overlying skin looks like: deep, purpuric, tense, shiny. And they're associated with a coagulopathy called Kasabach-Merritt. You see there's a star on this page, and there's also this coagulopathy is highlighted. You need to know about this coagulopathy. So this coagulopathy is only found in patients with this type of tumor. It is a coagulopathy defined as profound thrombocytopenia and profound hypofibrinogenemia. So the platelet count is usually less than 20, though a lot of times it's less than 10. And the fibrinogen is usually less than 100, and there is an increase of the D-dimers. So what do these look like on imaging? Well, I told you that they cross tissue planes. So MRIs are the imaging of choice to get for these patients. Sometimes they can look like a pedunculated tumor, but they always have what looks like edema or stranding on the outside of these tumors. This is a typical characteristic look of these tumors. This is not a well-defined tumor as we see with other kinds of vascular tumors, such as angiosarcomas. Sometimes fibrosarcomas can have a cutaneous stain, and so they can be kind of on the differential diagnosis, but fibrosarcomas look more like a well-circumscribed tumor versus a KHE, which again crosses tissue planes. They have a particular look on pathology. They are made up of spindle cells and also a lymphatic malformation. So you see the spindle cells here. So remember when I showed you hemangiomas, which are nice, normal, plump endothelial cells. These are not. They look like spindly cells. And they're sheets of spindle cells. They also can form these coalescing nodules and lobules. You can have a lot of bleeding and platelet microthrombi in there, that you can also have cells that kind of look epithelioid in nature, and these are the endothelial cells. And they stain positive for PROX1 because it is a lymphatic tumor. The treatment of choice. So on the lecture that I previously gave, there was a lot of different treatments that were used. But we have done a study, and the standard of practice now is really steroids and sirolimus. We had a study that was comparing steroids and vincristine versus steroids and sirolimus, but that study did not meet accrual because our standard of practice amongst all of the vascular anomalies in the pediatric hemonc world is steroids and sirolimus. This is something that you probably need to know because this diagnosis, the Kasabach merit, should be on the boards. So let's talk a little bit about sirolimus. So sirolimus is an mTOR inhibitor. I do have some other information about sirolimus in the appendix so that you have that, because I'm not covering things that aren't particularly on the boards. But sirolimus is a treatment for complicated vascular anomalies, mostly with a lymphatic component, and I list them here. But what I want you to know is that sirolimus is the treatment for KHE lesions and tufted angiomas. And there have been over 100 articles in PubMed supporting this, and this also is supported now in the scientific literature. Unfortunately, we will probably never get this approved because the pharmaceutical industry is not interested in approving this for KHE or lymphatic anomalies, and KHE is so rare that it would be a very, very hard indication to get this approved for. So what are the side effects of sirolimus? Well, we all know that sirolimus is used in transplant patients, so it is an immunosuppressive medicine. For our patients, particularly the infants, those infants that have KHE, it's very important for you to know that it is an immunosuppressive agent, that these infants need to be monitored very, very closely, that these infants who are on sirolimus need to be given PJP prophylaxis, because there has been in the literature reports of pneumocystis and patients who have died of pneumocystis that have not been supported with PJP prophylaxis. But some of the other most common side effects are mouth sores, headaches. It actually can also cause lymphedema, though we don't necessarily see that a lot on our patients. It can cause GI disturbance such as nausea, diarrhea, constipation. It can cause anemia, increase in the lipids, and rarely it can cause thrombosis, capillary leak, pneumonitis, and a question of male infertility. So it's pretty well tolerated in our group of patients. Again, I want to make you really aware that if you're using it in the newborn period, you really need to use PJP prophylaxis. So our length of treatment varies. For KHE lesions, to see a hematologic response, the average time is between 3 and 4 weeks. So again, you have to have a lot of patience when you're using it. Generally, it takes about 3 months to see response. The length of treatment for KHE patients is usually 2 years, and then we try to wean patients off. Majority will reoccur and have to be put back on sirolimus. The other thing that I want to mention to you, just because the Kasabach merit takes so long, 3 to 4 weeks, to actually see a response, you have to be very, very careful of platelet infusions for KHE patients. So when you have a patient with caposiform hemangioendothelioma that have Kasabach merit, it's very common in the NICU to want to transfuse when the platelets are less than 10,000 because they get nervous if CNS bleeds. But this is a very sticky tumor, and platelets, the granules, are pro-angiogenic. So when you actually transfuse with a lot of products, all the products will actually go into that lesion, causing more angiogenesis and more proliferation. And so your lesion can worsen, and it can worsen your platelet count. So we try not to transfuse with platelets unless someone is having surgery or a biopsy or a line placement. And then we actually try to keep our fibrinogen above 100. So we give cryo to help with that. And that actually helps with the stability of the endothelium. So what are some other malignant vascular tumors? And I believe you need to know about this too. And we're talking about, these are very rare, but talking about some of the most common ones. So the most common ones is angiosarcomas and epithelioid hemangioendotheliomas. So epithelioid hemangioendotheliomas, what we call EHE, has a peak incidence in the 4th and the 5th decade, though it can definitely occur in younger patients. It has a varied course. Patients can present with pain, effusions. There are some high-risk features, and those do include if someone has effusions, if they have symptoms, if the size is greater than 3 centimeters, if you have a high mitotic rate. And I truly think that in the pediatric age group, if you have disease in 2 or more places, that puts you in a high-risk category as well. There is a WWTR1 CAMT1 gene fusion, so I think genetics are very important, and less commonly a YAP1 TFE3 fusion as well. Treatment sometimes is just observation if you have a single lesion in the bone. We use mTOR inhibition with sirolimus, and we use some targeted therapies, but since the numbers are so low, we really don't have a standard of practice for this. I think what you need to be aware of is that EHE is a tumor that can occur in different sites, that it can occur in pediatrics, and you need to know the gene fusion that's associated with it. Angiosarcomas are also very rare tumors. They occur in 2% of sarcomas in general. They're very aggressive. They can occur with other risk factors such as radiation exposure, chemical exposure, or sometimes in our malformation patients. 20% of them can be GLUT1 positive. I think that is very important for you to know as far as a differential diagnosis. There have been some reports of the transformation of infantile hemangiomas of the liver and other lymphatic anomalies into a more aggressive phenotype, so into angiosarcomas. So I think you need to just know that angiosarcomas are a childhood vascular tumor that is very aggressive, and I think you need to know that 20% of them can be GLUT1 positive. So this is a summary that I'm actually not going to go through completely because I think I've been hammering it into you. What's the difference between an infantile hemangioma, a congenital hemangioma, KHE, and angiosarcoma? But I think I would really take a peek at this table and really try to understand it before you take the boards. So let's talk about vascular malformations. And again, I will highlight with a star and really try to mention those things I think are important for you to know. So vascular malformations in general, too, have a lot of heterogeneity amongst them. So in this picture, these are all vascular malformations. This is a lymphatic malformation with a microcystic lymphatic malformation, so not big macrocysts. So you can imagine this would be very, very hard to have a patient undergo surgery to remove this. And obviously, this is a patient that's probably going to need a trach. The center picture is a patient with a capillary malformation, and it's important to know that capillary malformations are associated with other syndromes. They also can have pyogenic granulomas, which are these nodular areas that can bleed, and a lot of times hematologists are consulted because they think people have bleeding disorders when they have this. This is a picture of a patient with a multiple hemangioma, and it looks like it's a very benign lesion, but this patient had about 50 of these all over the body and a coagulopathy. And we're going to talk about this in detail. So not the coagulopathy Kasabach-Merritt, but a coagulopathy that venous malformations and some lymphatic malformations have because of uptake of and use of coagulation factors. This is a venous malformation that also had some problems with coagulopathy, and this is a combined lesion. So capillary malformations can be extensive. They can darken over time. They're usually treated with laser. They are associated with other syndromes, such as Sturge-Weber syndrome. So if you have the distribution in the V1, V2, and V3 area, you have an increased risk for Sturge-Weber. Sturge-Weber is associated with glaucoma. It's associated with lesions in the brain, with seizures, and there's some treatment for Sturge-Weber now with aspirin and also mTOR inhibitors, and these are GNAC mutations, and hopefully we'll have some treatment in the future. Venous malformations, you see there are some bolded terms in here. So venous malformations are always present at birth. Sometimes you don't know that they're there. They can be bluish, soft, and compressible. In this child, this is just the beginning of what's actually seen. So this child had a massive venous malformation all through her face, her mandible, maxilla, and also down into her neck. But this is really just the surface of what you're actually seeing. These can be involved in the muscle, the viscera, the brain. They are thin-walled, dilated, sponge-like endothelium. Because the endothelium is abnormal, they can activate the coagulation system. You can have something called localized intravascular coagulopathy, but it's not necessarily localized because patients with these lesions can have increased D-dimers, low fibrinogen. So low fibrinogen, sometimes less than 60, but sometimes between 60 and 100. They can also have low normal platelet counts depending on how much disease they have. Venous malformations are associated with syndromes called, one of the syndromes is blue rubber blood nevus, and they're also associated with TIE2 mutations. Again, focus on the bold picture on this slide. I'm going to just push this and stress this a little more, but this is why patients with venous malformations can have problems with coagulopathy. They have an abnormal endothelium, so structurally and also functionally. There's abnormal size of these vessels, and so the blood is slower through them. Remember, these are extra veins. These are not the normal veins that you have, so they're more ectatic. They're more like embryonal structures. And this is what leads to this localized intravascular coagulopathy. Again, we're stressing this. This Coagulopathy leads not only to bleeding, but it also leads to clotting. So this can be very confusing, and it can be even confusing for people who do coag, who are hematologists, because people have a risk of bleeding and clotting. And in order to stabilize the endothelium, low molecular weight therapy and also DOACs work. So sometimes it's hard for people to understand that when you have these lesions, giving a little low molecular weight heparin will stabilize the endothelium even if a patient is bleeding. So we know there are higher risk diagnoses. Those include the venous malformations, some of the combined lesions like the capillary lymphatic venous malformations, a syndrome called Klippel-Trenaunay. We know that patients that have Clove syndrome have high risk of big, large ectatic veins, and they're prone to thrombosis. We know that when you do baseline labs, if someone has a mild thrombocytopenia, or a low fibrinogen and high D-dimers or ectatic veins, those are the patients who are at higher risk. We also know that this coagulopathy worsens with surgery, trauma, and puberty. So again, here is a important slide for you to know, differentiating the coagulopathy in vascular malformations and in that tumor called KHE. So KHE is associated with a purplish violaceous tumor. Vascular malformations are present at birth, and they can be venous or combined. They're not as purpuric, they're not as indurated, they're more diffuse. KHE has profound thrombocytopenia and hypofibrinogenemia and high D-dimers, and sometimes the PT and the PTT are normal, versus vascular malformations that have mild thrombocytopenia, hypofibrinogenemia, but not as low, and they have very high D-dimers. In vascular malformations, there's a risk of bleeding and clotting. In KHE, there's more so a risk of bleeding. KHE is caused by trapping of platelets and factors, versus in vascular malformations, you have the consumption of coagulation factors. KHE is treated with mTOR inhibitors. It's treated with medications that treat the tumor. In vascular malformations, you use low molecular weight heparin, you use DOACs, and actually you can use mTOR inhibitors, but it doesn't stop the growth because it's not a tumor, but it stabilizes the endothelium. So this is an important slide to know. Let's talk about lymphatic malformations. So lymphatic malformations have their own classification. Lymphatic malformations can be simple or more complicated. Usually they're localized, but they can cause problems depending on where they are. The most common type of lymphatic malformations is the macro-microcystic lymphatic malformation that you see here. Sometimes these patients can have problems with cellulitis, and that's what this patient had. They can be more commonly in the head and neck area. They can be treated with sclerotherapy. Most of these patients have a PIK3CA mutation. Generalized lymphatic anomalies are nice to know, but I do not think they'll be on the board. So a generalized lymphatic anomaly is a lymphatic malformation that can occur with disease in the lung, bone, GI tract, skin, and you can have bony lesions. This is a patient that presented with a chylous effusion that was initially seen on the solid tumor service because of the effusion, but also because of the bone lesions. Generalized lymphatic anomalies can be treated with sirolimus and also bisphosphonates, and they also have a PIK3CA mutation. Gorham-Stout is a disease that causes massive osteolysis of the bone. It can be associated with soft tissue structures and inflammation around the bony disease, but you can see this patient is actually missing the spinal processes. This patient went on to lose all the bones, even with orthopedic intervention, and unfortunately died. These are treated with mTOR inhibition. We're learning a lot about GSD. Sometimes they're PIK3CA and sometimes they're KRAS mutations. Kaposiform lymphangiomatosis is a very rare diagnosis that to me is more like a tumor where you have spindle cells, you have hemorrhagic effusions. These can be associated with coagulopathy that truly is very much like Kasabach-Merritt. They're very rare. They have an overall survival rate with sirolimus of 50%. They are NRAS mutations and they are treated with sirolimus, vincristine, and steroids, but now we're trying to use Mekinist to be part of it. We do have newer techniques to evaluate other types of lymphatic malformations, like there are central collecting lymphatic anomalies. Again, these are important for you to know just the distinction between them. So this is an MR lymphangiogram where you see a patient that has KLA with this extremely tortuous thoracic duct. You really shouldn't even see a thoracic duct like this. It should be a little thin line that you see. And this patient is dumping their lymphatic, chylous lymphatic into the lungs. And so this is a patient that had significant collecting problem with their KLA. So important to know, so how do I differentiate these lesions from a malignancy? So typically, when you have an effusion, there are no atypical cells. So when you have this patient, and if you were to evaluate the effusion, you really want to send it for cell count. You'll see, lymphocytes. You also want to send it to pathology because there, again, have been patients that have had lymphangiosarcoma with effusions as well. When you have someone that has a history of a soft tissue mass with the bony disease and it looks like a vascular malformation on imaging, that sometimes helps you differentiate them from a lymphatic malformation if they had the mass prior to coming in with the effusion. If you see multiple lesions in the spleen has very typical lesions for lymphatic malformations, and that can give you a heads up that this patient might have a generalized lymphatic malformation versus a malignancy. When they have a coagulopathy, such as the KLA patients, when you do a biopsy, if there's any question at all, a biopsy has to be done, except you should not be doing rib biopsies because a rib biopsy can cause a leak that doesn't get better. So you can biopsy other areas of the soft tissue. Depending on the location of the lesions, whether the effusion is chylous, whether there's protein losing enteropathy. So in general, these are some of the ways that you can help differentiate if this is a malignancy or not. I put this in about Clove syndrome because this is important, as you see in bold. We talked about Clove syndrome being a PIK3CA disorder. So it stands for congenital lipomatous overgrowth. So you can see all the lipomatous overgrowth in this patient. Vascular anomalies. This patient doesn't have any particular vascular anomalies. Epidermal nevi, skeletal anomalies. And these are the patients that also can have ectatic veins that make them prone to thrombosis, but there also is an association with Wilms tumor. So there is an increased risk of 3% above the risk in normal patients for Wilms tumor. So these patients will need to be screened for Wilms tumor. And that could definitely be on the boards. So this is for you to know. This is pretty well known what is PIK3CA associated. And so I think you could potentially get a question about cloves and PIK3CA association. You could potentially get a question about the Kaposiform lymphangiomatosis. I think I really put this in for you to know that we have somatic mutations, and the somatic mutations are the same somatic mutations that we actually see in cancer patients. So we will be using cancer therapy to treat our patients, though in a different way that you use it for malignancies, and also stress the need as to why hematologists, oncologists need to be involved in this field. So I want to thank everyone, and I want to wish you the best of luck on your boards. Again, I have attached an appendix that gives you some extra information on propranolol, some extra information on sirolimus. I'm always available if you have questions. You're the second group that will have questions on the exam, and this lecture will continually be changing as we add new things. I want to tell you that we have a consortium that has 16 sites, that ASPHO has a special interest group, and there are over 150 participants in this group. So you will definitely be seeing vascular anomaly patients. So thank you so much for the opportunity to give you this talk.